Okay, you're good to go.
Thanks. Good morning, everyone. My name is Jennifer Donovan. I am the Senior Policy Analyst for the Universal Health Plan Governance Board. I am joined today by Katie DeLuca, the board's administrative assistant. Katie will be running the technical portion of the meeting today. So welcome to the Universal Health Plan Governance Board's Principles and Values Work Group. This work group was formed as a space for members of the board to have a conversation about guiding values and principles that the board may want to add to those provided in Senate Bill 1089 and the Oregon Constitution. For members of the public watching, we will not be taking public comment during this work group today, but the group will present their recommendations or their findings to the board. Public comment is invited during meetings of the board. You may provide verbal or written public comment to the board. If providing written comment, please submit that comment on the UHPGB website. That website address is at the beginning and end of this presentation, at least 72 hours before the monthly board meeting to give board members an opportunity to review your comments. If you'd like to provide verbal comment is accepted at the end of each board meeting. For the agenda today, in just a moment, Katie will call the roll. Then we will ask for a board member of the work group to serve as the group's facilitator to promote productive discussion and be the voice of the group to report back to the full board. Once that is done, we will move into the discussion of values and principles. This will be the majority of the time today. We will be referencing some of the documents previously reviewed and posted in the board meeting from May 16th. That link is also at the beginning and the end of the presentation. I have included a few slides to remind us of the values and principles in Senate Bill 1089 and Measure 111. The meeting will adjourn at 11:30 a.m. this morning. Does anyone have questions? Okay, so we are going to move into discussing the facilitation of the meeting, and I am going to hand it over to Vice Chair George.
Actually, really quickly, I'm going to take roll call.
Oh, I'm sorry, Katie, go ahead.
No problem. Chinwei Chi.
Yes, here.
Amy Fellows.
Here.
Michelle Glass.
Here.
And Warren George.
Here.
And then we will have Debbie Diaz as well as a part of these meetings going forward, but she already had a previous commitment at this time. Thank you.
Okay. Just want to remind everyone that this is an open meeting for observation, and that we are being recorded. I'm just curious, Katie, if you could tell us the number of people who have registered to attend.
We had about 12 people registered to attend, and right now it looks like we have 4, in addition to our group, 4 online.
Okay, welcome to everyone from the public, and we encourage you to attend these meetings, understand the deliberations that we're doing, and feel free to provide written comment and oral comment at the full board meetings. We will now choose or see if anyone will volunteer to be a facilitator for the group. This is a standard list of facilitation duties. Do we have any of the board members who is interested in being a work group facilitator? Seeing no hands, I will proceed as facilitator, but if others do wish to participate, particularly in presentation of our deliberations to the full board, I think that would be highly appropriate. Getting into the discussion, we were greatly helped by Chunwei at our last board meeting, the discussion of framing and ethics. We started actually by a couple of givens. One is we're working within a framework of Oregon, which passed Measure 111 and includes some specific language about affordability, clinically appropriate care, and the third one, which will probably appear in a slide soon. And as well, we have, yes, cost-effective, clinically appropriate, affordable care. Thank you, Katie. And as well, we have some wording in values and principles that was included in Senate Bill 1089. And I think most of you are familiar with this language. So we're not going to do anything to change the wording that is already in statute, but we're also looking for guidance and framework for the work that we're embarking on to create a universal healthcare system for Oregon. And now I'd like to commend Dr. Chi again for the excellent presentation. And I'd just like to open it up to board members for any thoughts that you had or questions that you would like to address to Dr. Chi. I would start out by my own questions include, I think it's an excellent framework, and I was particularly taken by some of the work that involves public input, I believe, in Chile, and as an example. And Chunwei, if you wouldn't mind talking a little bit about what other countries have done to involve the public, to involve public in determining the values and principles discussion.
Yes, thank you, Warren. There has been a very little empirical work actually done for a national health system in terms of soliciting value and principles. And most of the work done in other countries involve public actually originated in Oregon. And during the last board meeting, I mentioned that from 1989 to 1992, when Oregon was developing the OHP, the Oregon Health Plan, the original Oregon Health Plan actually quite comprehensive with the ultimate goal of universal health care. But when it was discussed, deliberated in the state legislature, most part related to universal health care were dropped. And to the end, it only kind of minimized to the expanded Medicaid, that's what today we call the OHP. But the pioneering work that Oregon led the world was not specific about value and principle. It's more of involving the public in setting priority. So this is exactly what I have seen around the world in terms of involving the public's value, not the kind of abstract value itself, but a very concrete public's preferences for priority. And so the two papers I submitted as a reference for this issue, probably among the earliest published one, at least published work, that actually ask the question about value and principles. And so the one was done in 2016 in Taiwan, and then the other one 2019 in Chile. So in both Taiwan case and Chile's case, they use a different method. The Taiwan's case using the currently quite popular in called citizen jury. And the one in Chile is a more innovative way, try to help the public to make an informed choice, because equity principle, value and value are very abstract and difficult for the general public to contemplate. So in our survey, we actually use pictures and use tokens, use example to help the survey sample of about 1,200 random sample of Chilean people. So these are average Chilean people with a mix of literacy and educational comprehension levels. So we used pictures and tokens to help them understand those distributive justice principle has a concrete application. So we used the heart transplant as an example, and showing 3 different kind of people representing different age, gender, social group, and give people the concrete idea that if you choose principle X, then based on this principle, who will get the heart? If you choose principle B or Y, then the consequence of who will get the heart will be different. So if we want to obtain the public's preference in terms of value and principle, which often is very abstract, and this kind of survey will need to provide very concrete example so the public can relate that what those abstract distributive justice means in actual policy, in actual system. So these are the 2 examples. And in Taiwan's case, we involve a small sample but representative sample. The citizens jury usually cannot accommodate large sample because the end result is try to reach a consensus, not a majority vote, but a consensus. And to reach a consensus, it doesn't accommodate large sample. And so it has to be selective, but each representative has to altogether have to have an adequate representation of the social demographic group of the society, which we did. And the citizen jury is not a survey, but it's through deliberation. That's why it's called juries. And so the citizen jury's method is a long, take a long commitments, because it also involves experts presentations, because those people are dealing with some technical information, such as prioritization can result in who benefit, who suffers. And so they need to have information about what is the current social demographic and current access to healthcare, current distribution of disease, etc., before they went on to deliberate. So both represent 2 different methods of soliciting public values and preferences. But what I have in mind is the more narrowly focused one that we probably have to pay more attention, since both the Measure 111 and Senate Bill 1089 has laid out some of the broad ethical principles and values, but it didn't lay out the more detailed one, particularly when it comes to prioritization of healthcare. And so there are, in my opinion, there are kind of 2 levels of discussion we probably want to engage. One is the broader level and the fundamental level of what should be the principle of distributive justice that we can rely on when we come to the difficult decision of both designing the first generation of universal health plans coverage But the ethical principle is not just for the initial development of the coverage, because once this universal health plan is implemented, as I mentioned in part of my presentation or discussion, that what Taiwan's universal healthcare left out was a clearly laid out distributive justice principle in setting priority. And in the absence of that clearly stated principle, it left out so wide open room for political maneuver. Because every time when there's a new technology or new drug become available, then there's a political maneuver. The interest group in Taiwan, they call patient group. That patient organizes a group to lobby the government that this drug or this technology should be covered. And so since its implementation, what technology, what healthcare or new drugs should be covered become an ad hoc and also political maneuver. And this is what I really want to prevent, that without such clear stated principle, then we will face the same situation, that it's up to the groups, the interest group with bigger voices, they will get a bigger share of the resources.
Michelle and Amy, do you have any questions or observations about the presentation?
I do have a question.
Yes.
This is Michelle speaking. Thank you so much, Dr. Chi, for that kind of overview and kind of your thoughts at this point in terms of what you think has worked and what some gaps have been in implementation in Taiwan. I guess one question I had going into this meeting, it's not a response to what you just said, is there any reason, as I was reading through ethical priority setting for universal health coverage, challenges in deciding upon fair distribution of health services, I couldn't see any reason not to adopt the 3 accepted criteria as further clarity at a minimum: promote health maximization, fair distribution, and protection against poverty. In your mind, Dr. Chi, is there any reason that we shouldn't or should have caution in adopting any of these 3?
No, I fully agree. These are very important principles. But again, the specific distributive justice principle is related to the second point, fair distribution, and what is the definition of fair. There are potentially dozens of different definitions of what constitutes fair. And that is precisely the distributive justice principle try to clarify, to make it clear what is our definition, our notion of fair.
Thank you. Yes, that makes sense to me, and I agree. I guess in terms of process, my thought is that we would have to recommend adoption of these 3, and then go a step further. Like if we don't adopt if we don't adopt fair distribution as a value and principle for this work, then that seems to me like a prerequisite to further defining what we mean by fair distribution. Like we would kind of need to do this and then that.
Yes, I fully agree.
Okay.
This 3 principle as a broader general principle. But then once we decided to adopt them, there's more work. And actually the devil is in the detail. So for example, even for the first principle, promote health maximization, that's a very broad concept. But then the detail is, whose health shall we maximize? And then when we ask whose health, that means among all social demographic groups within Oregon, there are inequality in health. So whose health shall we promote and maximize? And that will lead us back to what distributive justice principle shall we adopt. Let me just give you an example. A very large proportion of health economists generally adopt the utilitarianism principle as a distributive justice. For utilitarianism principle, the implication applying to those three principles would be, for example, promote health maximization. If we or someone choose utilitarianism as a distributive justice principle, then we ignore whose health that questions. We only look at the total population health indicator average. That's what we maximize. And we totally ignore the distribution. We ignore, because that's the principle of utilitarianism. You want to maximize the maximum number of people's health, but not paying attention to how that maximization was distributed among the population. So that's just one example. And then let me just give you another example. The Rauschen principle, which want to maximize the health of people at the bottom. So that will have a very different policy implication on whose health shall we maximize.
If you'll excuse my interruption, I guess from a standpoint of, we've got Amy. We haven't heard from Amy. Please, Amy.
I just wanted to, I mean, maybe where I'm going is kind of more in the details and less about these three broader principles, but a lot of my focus has been around people with disability. And I know a young man who had to fight for a heart transplant because he's non-speaking autistic. And this was in 2012, and had to fight with Oregon Health Plan, and then again to actually get someone to do it. But because he was able to, and him and his mom had time to figure out communication, his mom is now teaching other parents about how to communicate with their non-speaking autistic children. So like, I guess I say this story just to point out, like, when other people perceive value on humans, then, you know, we don't know what their capacity is unless they have a chance to live healthy and happy lives. And because, you know, somebody gave this young man an opportunity, now he is working with his mother to improve other people's lives, if that makes sense. So I guess that kind of, I don't know, is what I think about when we're looking about some of these principles and fair distribution and fair to who and things like that.
Oh, okay. Thank you, Amy. And getting back to Michelle's astute observation about process, I think it would help the process if we just check consensus, if we believe that these three main points here are a good starting point, and then we'll have to look at each one of these in more detail. I can think of other things that I might add, but they are mostly subsets that kind of go under these three. So do we have by nod or show of
Want
hand?
to do a fist of five, Warren?
Yeah, we can do
Remember,
fist of
five is all in, fist is I disagree. And then
yes. So do we have agreement on these three principles as being kind of fundamental places to start? Yes, we do. And so now, just taking the first one as an example, promoting health maximization, I think there is a real question of how we measure that. And in Junwei's presentation, we talked about things like quality life years. Or maybe it wasn't there, but patient satisfaction or life expectancy. Amy, do you have a comment you'd like to?
I just want to remind us that the quality adjusted life years are now no longer allowed to be used in Oregon. Disability Rights Oregon fought for about 20 years to get those off the books. The quality adjusted life years are QALY. And they finally passed a bill this last session that ended the use of QALY in Oregon.
Thank you. I was aware that they had been outlawed. Some places were still in use in other places. Chunwei.
Yes, to follow Amy's comment, the quality adjusted life years was actually the initial method OHP used to prioritize healthcare. And so the method they used was cost utility analysis. So quality is a utility measures. And so the initial prioritization of OHP's 720 condition treatment pair was purely based on cost utility analysis. But that result didn't work because when first time it published, there's a lots of criticism. It doesn't make sense. And so, for example, tooth extraction was put a much higher priority than the appendectomies. And there were many like that. That's why they had to went through 2 rounds of around the state, county by county, public hearing and the public input, and to readjust the priority list. So the quality was originally used in 1989 in Oregon priority list. I also just have one short comment. Of the 3 principles, it's the first 2 that require a lot more detail. The last one is relatively straightforward because we have a clear definition of what is poverty according to the federal poverty guideline and measurement. So that protection against poverty is relatively straightforward. It's the first 2 that needs operationalized, needs more detail.
Other comments relative to Chunwei's discussion? And for myself, I think there needs to be some measure. I mean, if we're going to maximize health, what do we use as some sort of measure? And quality life years is certainly problematic, and as Amy points out, not useful in Oregon. But Amy, I guess I'd ask you what other measures might be useful. I mean, how do we know that we're winning or doing a good job? Yes, Amy.
I don't know what to say about what to use, but I do know the reason that QALY is discriminatory was it was based on a survey in Scandinavia where citizens kind of rated the quality of life that other people would have based on conditions. And so the example that Megan Moyer from Disability Rights Oregon would give when she would come to meetings this legislative session is that someone who's autistic would get a multiplier of 3, and then that would reduce their opportunity for potentially some life-saving measure. And that was because of a value judgment Scandinavian citizens had against other citizens who may be autistic. So it is clearly discriminatory. And I think whatever we use, we need to really look at how people with chronic illness and disability are treated, and and anything that we might consider using.
Chunwei.
Yes, let me just supplement what Amy comment, because I do teach those measurements. And globally, there are 2, we call it complex health measurement. Quality is one of them. The other one is DALY, disability adjusted life years. Both are subjective measurement. And in my opinion, DALY is more problematic, but seems more popular because the World Bank and WHO and Gates Foundation are promoting it. If you get a grant from Gates Foundation or World Bank, you must use DALY. That's why DALY become very popular. But among health economists, they still favor quality. The real problem, as Amy pointed out, was Oregon was not developing its own quality because quality is a subjective survey. You selected a representative random sample of the citizens or residents and conduct a very comprehensive survey asking their value preference in terms of health state. And the survey measures are the same for DALY or quality, but the dimension is very different. DALY is very narrowly focused only on disability, but quality is very comprehensive on the overall quality of life. The key issue is if Oregon is going to use quality, that quality table has to be constructed based on Oregonians' survey. We cannot simply adopt other countries because actually UK was the first country to construct a complete quality table. And since then, this was in the early 90s. Since then, they have used that not as a strict guideline, but an important guideline for their prioritization of national health services in UK. For example, the UK also has a government institution, NICE, the National Institute of Clinical Excellence. They routinely assess all healthcare services and technology, and they develop a general, not a strict, but a general guideline for the government to decide which services to cover, which service not to cover. And their recommended guideline has been, if to extend one quality, it costs then 20,000 pounds. That's roughly around 30,000 US dollars. So if extending one quality costs less than 20,000 pounds, then without doubt, government should cover. If extending one quality costs more than 30,000 pounds, then government should not consider, and again, this is just a recommendation, not a strict guideline. So above 30,000 pounds per quality should not consider. And then there's a gray area of between 20,000 pounds and 30,000 pounds. And they recommend in this gray area, the government need to do further investigation. So that's as a general guideline, how the British National Health Services, to a large extent, they have been following that. And so when they develop that complete quality league tables, I was engaged in an international health policy network discussion. It was an email network. And there were people from economists from Australia and other countries were excited about the British quality table. They want to adopt it. And I jumped in to object to that. I said, quality is very subjective. And if you conduct the same survey in Australia, you will not get the same result as they have in UK. And so the problem in Oregon was we did not develop our own quality. We adopt other countries' quality table, and that's problematic. So the problem is not the quality measure itself, but it's we didn't conduct our own. If we are going to use quality, it has to be based on Oregonians' preferences and values.
Getting back to Amy, I want to be clear for myself. The quality adjusted life years has been is not consideration in Oregon, but what about the DALY, the disability adjusted life years? I'm not sure I
don't
really
know.
understand the difference. And
The bill was
hopefully-
specific to quality because that's what, OHP has always been based on. I think this is an area where it would be important to get input from people like the folks at Disability Rights Oregon as we move forward. because I don't know their thoughts on these other measures.
And I agree. And speaking for myself, there is a measure of, taking things personally, at my age. And if there were a priority to be set, my grandchildren I would give them higher priority than myself. And I think that's kind of an obvious principle that most of us would accept, but perhaps not everyone. And how do you quantify that? Michelle, do you have an opinion about these issues?
Have more opinions than are useful, but relevant to this discussion, one of the things that I'm thinking about is, there's we could use a specific measure, but there's like objective measure versus process. And I'm thinking about the Oregon Health Authority definition of health equity that was developed by the Health Equity Subcommittee of the Oregon Health Policy Board and adopted by the Oregon Health Policy Board, and the Oregon Health Authority's goal to eliminate health disparities by 2030. And to me, this work fits, within that larger overarching goal and framework that the state has established. And so as I've been trying to think through I don't know of a measure that just gets us to health equity, but there are process recommendations that I've come across that try to eliminate biases and create a dynamic way of continuously working towards health equity outcomes. And so a couple of those are, I think having a measure will be important. And I think I'm thinking of it as both and. Like if we have some kind of body, I think I'm in favor of something closer to a citizen jury than just a survey. But if we have whatever body that is guiding this work on an ongoing basis, implementing the distributive justice principle for this work, there are some recommendations such as having anti-bias training or unconscious bias training for everyone involved in that process as a starting point, and then having checkpoints regularly to assess trends in resource allocation and clinical outcomes as things change, such as Dr. Chi was just referring to, new technologies, new drugs, those types of things. And then looking at the resources provided for and the outcomes of patients on a regular basis by real D, right? Race, ethnicity, language, disability, those types of considerations. So I think that I'm thinking more of the process considerations, because I think that is where health equity lives in my mind. That's what I'm more familiar with. And I would defer to Dr. Chi's expertise in terms of some kind of measurement. But I think we need both. We need a measurement, but we also need to think about who are the people applying whatever that tool is, and how are we setting up a process so that those people are resourced appropriately and have a process that allows for checkpoints throughout the years, so that we are continually making sure that our outcomes are aligning with our principles.
Amy, you have more comment? Okay. For me, speaking personally on the health maximization, it guides me. I think our principles should be that we adopt should be kind of actionable. So, for instance, the promoting health maximization is actionable to me, and since, for instance, if I know that payment at time of service discourages certain populations from seeking diagnostic care, cancer screenings, then I am led to say, how do we, I'm thinking big here, but how do we turn cancer screenings over to public health departments or something on a free basis? That's the kind of thing that I would do to try to achieve health maximization is avoiding the intimidation factors, for instance, that discourage care. But I still think that there are issues here. I'm listening to Michelle and all of the things that you can't make decisions on, and I think we'd probably would all support those. But if there's nothing that we can make intelligent decisions on, then we end up looking at things like a lottery system, or that operates more like a lottery system. And I've read certain information about Stanford, the transplant center that used to have standards based on, we will accept this transplant patient over this one because he has a supportive family, he has a good job, and these are all factors. And those things have been pretty much thrown out now to first come, first served. So there's a list, and if you die before you're on there. But I guess there's part of me that really says there should be some kind of intelligent criteria, either based on age, two equal patients, and one is 20 and one is 85 waiting for a transplant. I would hope that we would make a particular decision there, and I don't mind saying that out loud, but I'm hoping to engage more conversation. Michelle.
I hear you, and I think that is obviously comes from a really great place. I am curious. Part of my work with the Regional Health Equity Coalitions is working primarily with communities of color, and I am not sure that would be the same across cultures in Oregon. I think that cultures who really venerate elders and the wisdom that elders hold in communities might make the opposite, or might have a harder time, making that choice based on age. So, just to add that to the conversation, that I think it would take something like what Dr. Chi was referring to in terms of an Oregon survey to find out, what are the different ways that Oregonians think about these tough decisions. And not that one perspective is better than another, but I think there might be more disagreement than one would imagine on that point. One other quick note, I guess, or a question maybe. I see your hand, Dr. Chi. I am curious. I noticed myself getting really hesitant about using health economics, like over a certain amount or under a certain amount, to make recommendations without some kind of cost containment strategy. I think that is one of the big questions we're wrestling with, is do we just put people into the existing system, which is a system which generates profits for some people and bad health outcomes for many, and trap people in that system, or do we try to create a better system? And so I guess that's a question that I have, is if we were to use some kind of economic criterion to make recommendations, how does that work with our out of control healthcare costs situation that we have here in Oregon and across our nation?
Chun-Wei.
Well, yes, thank you, Michelle, for that very important questions. Let me first respond to your question, and then I'll come back to my comment related to the promote health maximization. Oregon actually, again, was the pioneer that led the world, particularly the academic world, to depart from pure economic decision. Because up till when Oregon tried to use cost utility analysis to prioritize list, the academic world around the world was heavily influenced by health economic decisions. That's why the UHP adopted that method in the first place. But then through that process, they discovered, no, economics or cost can never be the sole or not even the most important decision factors. And throughout the 1990s, the world of academic world of priority setting went through transformation that slowly moved away from technical process, which up till that time was the core focus or the only focus. So the world of priority setting have been transformed because of Oregon, from pure technical orientation to political orientation. By political, I'm using the ancient Greek sense, means it's neutral term. It means public affair. And also the political process means it's a normative process. That priority setting is not a scientific or objective process. It's a subjective, value-based process. And Oregon actually, again, was the pioneer in the world to show the world the case. So at the beginning of this century, the academic world of priority setting started to shift slowly towards how, given that priority setting is largely a normative process, a value-based process, in a democracy, those values should come from the public, from the citizen. And that's when those methods such as citizens jury started to be developed for exactly for that purpose. And then back to the promote health maximization. I'll come back to comment on Michelle's comment about not based on economic values, such as the British nice recommendation of having certain cutoff point. And I totally agree. The economic cost effectiveness should never be the top decision factors. It can only serve as a supplemental decision factors. For example, the economic efficiency can help only when we choose our objective. And I always use these analogies that the political decision of selecting an objective is like, in a travel analogy, like choosing a destination where you want to travel. And that choice is totally subjective. And there is no expert in that choice. But only when you choose the destination, then how to get there in a safe, cheap way, the professional, the expert can help. And in that analogy, only after we choose what health we want to maximize and how to maximize it, the economic can help. But economic cannot help us to identify the objectives. And so back to the first principle, promote health maximization. Let me give you two examples also related to Warren's earlier example of age. In the Chilean case, we use the heart transplant between an elderly 75 years old versus a 30 years old woman. And who should get the heart depending on the distributive justice principles. And the British national health system, again, they not completely, but largely follow this principle in health equity called equal access for equal ability to benefit. And so if we base on that principle in the example we use in the Chilean survey, the 75-year-old, besides heart failure, need a heart transplant, also have multiple chronic conditions, where the 30-year-old woman has only heart condition that need heart transplant, otherwise healthy. So if we follow that principle, then the young woman should get the heart because she has better ability to benefit from the heart than the 75-year-old. So it's not purely based on age, it's based on ability to benefit. But again, when we change the principle of equality in health, and the health is measured in quality, so this is where it gets tricky. If the equity principle is focusing on equality in health, and then it comes down to which health measure do we choose? If we choose life expectancy, then the 75-year-old already lived 75 years, but the 30 years old only has 30 years. So in equality of health measuring in life expectancy, the heart should go to the 30 years old. However, if we choose quality adjusted life years as the measurement of health, then assuming this 75-year-old who has been suffered from multiple chronic diseases since young age, then his 75 years age can transform in the scale of quality adjusted life years can turn out to be lower than the 30 years old women. And in that case, the 75 years old should have a priority to get the heart over the 30 years. So this is why which health measurement we use can also matters. But again, back to earlier Michelle's comment, the promote health maximization, the measurement or indicator is in the secondary concern. The primary concern, again, is what I raised earlier. Whose health shall we promote to maximize? And let me just give you two different examples. If we want to focusing on bridging health disability, then if that is our principle, then the people with lower level of health should be the priority to maximize. Because if the goal is to bridge the health disparity. On the other hand, if we want to promote health in a non-discriminatory way, then irrespective of people's age, gender, ethnicity, geographical location, gender orientation, or all, irrespective of all social demographic category, everyone's health should be treated equal to maximize. So these are two very different implications.
And I would like to throw in just a couple of things here. One is as we talk about, specific examples of priorities or triage. One of the reasons I got involved particularly in universal health care, is the realization that even if I completely ignore whatever measures that we're using or criteria we use, if I can cut, say, 10% out of the cost of healthcare, I have enabled significantly more care to be delivered without the question even coming up. I have avoided a certain amount of having to make the hard decisions or push them off into the extreme case. And I think that's something I wouldn't want us to lose sight of is that a major priority here can be, if we can reduce cost, we enable all kinds of good things. We enable more care to be delivered to everyone without having to decide which one. In comment, Michelle?
Yes, I agree. I think the more we can create savings and a system that works well for everyone, then I think we ensure the longevity of this project, and also, I think we maximize the benefits for most people. I guess to me, this brings up a question that we briefly touched on at our last full board meeting, which is how this universal health plan design fits with other initiatives in the state of Oregon. Because we do have targeted initiatives. We have OHP, we have innovations that have been happening with OHP to expand OHP eligibility and access to more people in our state. We have the bridge plan. And so none of my understanding, at least so far, is that none of those would necessarily go away. Like OHP will still exist with the eligibility criteria that it has. This would be in addition to OHP. This wouldn't necessarily replace. Is that correct? Because if that's the case, then I think that speaks to what you were just talking.
Well,
Inputs how we decide.
Going back to the task force, and I think it's something we really need to do as a board is begin defining these things with some ability to say, are we going here? Are we going slightly over this way? Or because there isn't really one thing called a single payer system or one thing called universal health care. Certainly, the task force envisioned a system where there's no more fragmentation. So that means that OHP as a fragmented system and the bridge plan, I mean, they're designed to cover certain segments that we would be looking for one system that would certainly from the standpoint of the provider, you couldn't tell who's who. You would have no reason to know or care, either in terms of your reimbursement or in terms of available services. So it's really looking at one single system. And part of the savings is that we put quite a lot of money into knowing exactly which patient we consumed those resources. And if we move more into things like global budgeting or even capitated care, we're getting rid of that cost, but now we no longer can associate a patient with a cost. We're just paying a certain amount of, saying, a global budget to a hospital that serves a regional area. And they get one rate. So there is no more, I mean, there are little parts of OHP that might still cover certain people if those benefits are not included in the universal care plan. But the idea actually is envisioned by the task force is that as long as for people who are generally served by systems that exist for public in each community, those systems would no longer exist. The ones that would survive would be those that have their own budget and their own delivery system. So for instance, the VA would survive and run in parallel with a Oregon Universal Health Plan. Indian Health Services would continue to exist. Certain other programs, for instance, if you prison systems, not open to the public, but anything that has its own budget would not be part of the universal care system. That could include if you pay a fee for access to an infirmary at a university, that would be outside the universal care system. But in certain cases, if you have an employer who is working in a remote area that doesn't have services and they provide their own doctor, so anything that's not really open to the public would continue, although that can get the details of that, as we'll find out later, can get hairy. But the idea is to end as much fragmentation as possible. From the look on your face, I see some concern, Michelle. So I see Jenny has a hand up, but I want to see if you have a response to that. I'm giving you the information from the task force that may or may not mean we go exactly the same direction. Michelle, do you have a,
But I wanted to pause and see if Jennifer had a direct response first. Because she raised her hand when we started on this topic, so.
I was just going to add sort of further to what Warren was saying, and I think the question is an important question as we look at the values and principles, in that the task force made recommendations and 1089 asks the board to consider those recommendations. And 1089 does not say that the board has to create a single payer system. And so I think the question you asked, Michelle, is a really good framing question when you're looking at values and principles, because I think the answer is, does the continuation of OHP help the board achieve health maximization in those values and principles? So the design factors that you'll be looking at will be designed according to the values and principles. And are we meeting with this design selection the values and principles that we're setting forth? So I think that like Warren just said, that's an open question. The task force did a lot of work on that and they made recommendations, but is it going to meet the ultimate goal of what the board decides are the values and principles and what they're looking for in terms of the outcome of the universal health plan? And the other thing that I wanted to mention to the group that might be useful in this conversation, we've spent a lot of time looking at the values and principles that are set forth in Senate Bill 1089. There's another section of 1089. It's section 2, and it's where the bill defines single payer. But after that, it talks about the board, the governance board is to create a universal health plan that is responsive to the needs and expectations of the families, of the residents of the state. And it sets forth about, I think, maybe 6 or 8 different statements that may be useful to the discussion. And the one that keeps coming forward to me in the conversation that you're currently having is that one of the principles is providing equitable access to person-centered care. And so looking at health maximization, a lot of the conversation has been around, do we look at it from an individual standpoint, or do we look at it as from a community standpoint? And I think maybe looking at some of the text within that section of the bill could, if nothing else, I think promote a little bit of conversation around at least the guidance that was provided to the board in the bill. And I'm sorry, it's not on a slide, but
yeah,
the chat function, so I can't send it to you. Send you all an email with it in there just for your consideration as you move forward with the conversation.
thanks, Jenny. I want, and I'm speaking personally here, when we consider what kind of measure is success, for me, it is very important in an environment where medical care evolves. I think it's important that the patient be given the benefit of the doubt in making decisions, using the provider as an advisor. I would hold my fist up to anything that says we're going to put everyone on a particular drug because the AMA says it's better for you. And so, but I don't know quite how to measure the idea of patient satisfaction. But the most important thing to me, even if it were at the cost of life expectancy, I want patients to have control of their care. Yes, Michelle.
I wholeheartedly agree with that last sentiment, Chair George. I think that agency is the heart of equity. We can't have there is no equity where we're forcing decisions on people. That's it's an oxymoron. It doesn't exist. So I think that that's really important. I guess what I'm wrestling with, I see a lot of benefits to a single payer system and to global budgeting. I guess my question is, if OHP gets folded into this plan and we have to design a plan for everyone, then to me, that seems more daunting to figure out how we get to equal outcomes, because we have, with OHP, we have a really focused program that is, its mission is to eliminate health disparities, and it's focused on the folks that are most impacted for the most part by health disparities in Oregon. And then the people who are not on OHP there's still some disparities, but it's the severity is less, is my perception at least. And so we're basically shifting people from commercial plans, which I'm on, which aren't great in my opinion, to something that would be better. So to me, that's the easier task, is to like take people who are currently trapped in commercial plans with high deductibles, et cetera, putting them into a plan where they actually are going to have better access, better coverage, and lower costs. I'm curious, Dr. Chi, the equal access for equal opportunity to benefit. In your experience, is that a principle that can both serve people who are currently maybe not experiencing the deepest health disparities, but wanting to have cost-effective, good quality care, and also eliminate health disparities for those who are most impacted by systemic inequality? Can it do both, or are we really needing to choose one or the other?
Oh, well, let me respond to that. The principle of equal access for equal ability to benefit, it doesn't necessarily alleviate disparity. It's just a principle. I think for equal ability to benefit has some weight from economics related to health maximizations, and there's a hint of utilitarianism, because the idea, and this is, we know the British society is quite heavily influenced by utilitarianism. After all, that's the origin of where utilitarianism started. So equal access for equal ability to benefit has a strong influence of utilitarianism, meaning we have limited healthcare resources, and we want to make sure our limited healthcare resources generate the maximum benefit for the society from a utilitarian perspective, and which why lead to that principle. And personally, I don't in favor of that, because that particular principle potentially can be counter to what we want to advocate to bridge the health inequality.
This is, to me, and maybe I'm probably missing something, but I guess one struggle I have is I am here mission focused on eliminating health disparities. And also, if we don't have a system that works well for everyone, then I think that's a political threat to the system's long-term existence, right? And so how to do both is what I'm really struggling with here. And I really appreciate your expertise and your experience that you're sharing here, Dr. Chi.
Before we go to Amy, I just wanted to clarify, Michelle, that when we talk about not having a fragmented system, the task force didn't rule out the idea that we would use much of the OHP framing rules could be the fundamental platform on which a single payer system works. It's not that we would have to start over on any of that, and the task force didn't rule that out. Amy, please.
Just a lot of this conversation is reminding me of kind of the equity versus equality conversation in terms of the fair distribution and like, you know, finding in many places and systems that those things still get confused. And I guess kind of wanting clarity around this group's like values and principles is, you know, like I know strongly where Michelle is. We're in a lot of meetings together in terms of health equity and focusing on, you know, vulnerable populations and improving health disparities. But then when we talk about things like fair distribution and utilitarianism, it kind of brings up the equality piece. And then also thinking about, you know, this, our purview is kind of about creating the system and the coverage side, but a lot of those disparities are in the delivery system side in terms of, you know, racism and ableism and other things that impact the patient once they hit the delivery system. And I don't know how much influence we have over that part of it. So I'm just kind of trying to wrap my brain around, is our value, you know, focused on equity over equality?
That's a tough one. Tough one for me to provide measurement. Chanwei.
I just want to add a comment on the concept of equity. Well, I think most of us all advocate the importance of equity. At the same time, when we are at the operational level, we need to be clear that there are multiple definitions and school of thoughts in terms of equity, which is why in the early meeting, I mentioned we need to identify what are the underlying ethical principles that guide us to define what do we mean equity. Because in the common usage of equity, people often assume there is only one notion, one definition of equity. But in the academic discussion, there are multiple notions, multiple definitions of equity, which is why we need to be clear about what do we mean by equity. And the term equity is very similar with the second principle, fair. That we often, in the common usage of the language, you often assume there's just one notion of fair. No, in strict sense, there are multiple school of thoughts. Fair is closely linked to equity. And just like there are multiple school of thoughts on equity, there are also multiple school of thoughts of what consider fair. Which is why in the first place, I raised this whole issue, that how do we address those issues? Because including in the bill 1089, those bill use those vague language. But we are at the operational level. We need to define them. We need to clarify them.
Michelle.
Thank you, Dr. Chi. I guess that's partly why I brought up, and I'm curious how folks feel about adopting as part of our framework. I guess I'm really struggling from a process perspective. I'm like very much a process-focused person, as I'm sure you can tell. Because there's all these like kind of larger framing questions that we're wrestling with at the same time that we're in the weeds with some specifics, and I find myself going back and forth. So I am curious how this group feels about adopting the Oregon Health Authority definition of health equity. And I want to add to that I think we all agree that we want equality. Like I hear equity and equality discussed in oppositional terms, and I don't actually believe that that is accurate. I believe we all want equality, but the problem is how do we get to equality? And if we try to give everyone the same thing, we will never get to equality. So equity is a strategy, in my mind, to get to equality as an outcome, right? So they're not in opposition. One is a strategy to the other. And in that spirit, I think OHA wants to have positive health outcomes, optimal life quality of life and life expectancy for all Oregon residents. And they have a health equity definition that has been developed and adopted to try and acknowledge and eliminate disparities so we can get there for all people, right? And so I'm not assuming everyone is super familiar with it. I happen to read it on a regular basis, but I'm a nerd. So I'm curious, like, is that something we need to email out? Is that something folks feel familiar with and ready to discuss? But I guess that would be one question I have is, can we operate and adopt the Oregon Health Authority's health equity definition as another tool in creating the clarity that we need to make these decisions?
John White.
Yes, Michelle, I fully agree with you about the importance of process, which is also my strongest interest and argument with my over the last decade of intellectual interest in studying governance. And governance is all about process, not about outcome. But the main debate in policy world is tend to focusing on outcome and then ignore the process. But from a self-determination principle, process is the outcome. Process should be treated as the outcome, meaning as we are discussing, deliberating what should be the underlying ethical principle guiding our priority setting, guiding our financial burden of the plan, universal health plan. One important issue, we may not discuss or resolve that on this meeting, but in the future meeting, we may discuss about the process. That is, what kind of process we should adopt in identifying the principle, the underlying ethics. And I fully agree with Michelle that for the time being, we adopt the UHP's definition of equity. But at the same time, I also suggest something we can consider. Given that the equity principle is a normative issue, it's a value issue, we should do our best, try to solicit that from the Oregonians. And a method like citizens jury is an appropriate method to obtain that. And so I have a suggestion that because we need to start working and developing many components of this universal health plan, we can initially adopt such as those three principles as well as the OHP's equity definition. But we can consider that as a working document, meaning there are potential room to modify, to improve, to change, depending on what process we choose to solicit the public values on ethical principle.
Thank you, Chunwei. And speaking of process, we've kind of moved gradually from promoting health maximization to discussions of fair distribution. I wanted to leave just a couple of minutes to talk about protection against poverty. And I will say that for me, what that means mostly is it's things like reducing cost sharing, because those are the things that we do to charge sick people far more than healthy people is actually, for me, is what's driving the poverty. So if we make decisions to eliminate co-pays, co-insurance, and greatly reduce or limit deductibles, that we are doing quite a lot to eliminate the issue of poverty. That doesn't mean that healthcare doesn't still cost a lot, but we're taking, to me, the people who, for instance, are bankrupt are those who face exceptional costs, which could be borne more generally. Chunwei.
Yeah, thank you, Warren. The fair distribution, in my opinion, and actually is the kind of the grand principle that related to the first and third principle. And the fair distribution, I can summarize in 3 dimensions. The first dimension related to the first principle, that is the fair distribution of health service and health benefits. So that's actually related to the first one. But then the second dimension of fair distribution is related to the third one, the fair distribution of financial burden. And Warren, you talk about eliminating cost sharing and co-payment. Yes, cost sharing and co-payment, they are potentially poverty-driven measures, but they also cause another very important negative effect. That's another important reason why we want to eliminate them. So besides causing poverty or financial hardship, cost sharing and co-payment, co-insurance, they also serve to deter people's use of appropriate health care. And with different kind of cost sharing, they generally don't deter people with high income from using necessary health care, but they set as a barrier. They deter people with low income from using necessary health care. So that's besides preventing financial hardship or poverty, this is very important reason why we want to eliminate cost sharing. And then there's a third dimension of fair distribution is how do we pay provider fairly?
We're about 9 minutes or 8 minutes from the end of the meeting. I did want to revisit some of the things that I've heard as that I would call highlights of this meeting. One is I think we have consensus that some survey or somehow determining how Oregonians feel about some of these issues is actually going to be an important part of perhaps our recommendation back to the board. Is that, do we have consensus on that? Okay. Another thing that I have heard is that we have some reluctance to propose specific measures other than perhaps patient satisfaction. I mean, it doesn't sound like we're very excited about using life expectancy, the QALY or DOLY. Is that pretty much, are we in agreement on that? Okay, I see 3 from Chun Wei, no response from Michelle, or so that will remain an issue of discussion. I'm hopeful that by next meeting, Jenny, if we could maybe have OHA, their health equity statement for us all to take a look at.
Warren, I have sent you all an email with the health equity statement and the Part 1089 I referenced, but we'll post it in the materials for the next meeting as well.
Okay. Amy.
I'm wondering, and I can find and send to staff to share with people, but if maybe it would be helpful for people to, if it's still an OLIS, and I'm blanking on the bill number, but look at the end quality bill, look at maybe the letters that were sent in opposition, you know, to get a better understanding of why, you know, that was ended before we can like have more conversation about the life expectancy type of metrics.
Amy, I already looked it up and I'll post it with next week's.
Okay, you have the list thing, so then you can see the letters and all that. Okay, thank you.
Is there anyone else, kind of major points of the meeting? I think I got some of those. Chanwei. You're muted.
I just have one suggestion for us to discuss next week's meeting is to discuss about the process. What kind of process the board shall recommend in terms of identifying and refining those ethical principles.
Okay, I would like to encourage all of us, and I hope that Debbie will be joining us next time, but to actually give a little more thought to the sub principles of this maximization and distribution and poverty. I did have one other item that I want us to consider whether we want to kind of take on. The task force was relatively specific that our scope was financial, that we were redesigning the financial system, and that partly because what we believed the public was telling us is they didn't want us messing with any part of how health is distributed, no change in your doctor, and yet as we get into the governance board, I'm seeing some issues in our scope, and there may be issues of delivery of care, for instance, that we can't actually address finance without somehow affecting at least a small part of delivery of care. But I'm hopeful to get a read from people on what our scope is. Are we really restricted to finance? And part of SB 1089 charges us with coming up with a financial plan. But how well can we color inside the lines? And how much consideration might we give to delivery, or even a little bit to spilling over into social determinants of health? So I hope that is, I would like to at least consider that next meeting of how we do that. Chun-Wei.
Oh, I just have one quick note in terms of the significance of involving the public is I suggest we seriously consider that in order for this universal health plan to be successfully established, but also maintained for a long last time, it's important to involve the Oregonian, the general public, so they feel they have the ownership of this system. This is not a top-down system. And that's why I'm very interested in thinking about the process.
And I agree wholeheartedly with that. I think we got 5 fingers from everyone on that. Jenny.
I just wanted to clarify. So in 1089, the board is charged with not just financing, but the administration of the plan as well. So there are broader decisions, I think, that you'll be making in terms of the administration and the financing that the task force sort of commented on and passed on to a certain degree to the board. And the one other thing I wanted to say, since it is 11:30, is just to remind everyone that we will be meeting again next Wednesday, that's June 5th, at the same time. So the meeting will be from 10 until 11:30 again.
I'd like to thank staff for their excellent support, and thank you, Michelle, Amy, and Chun-Wei. Look forward to meeting again.
Thanks all.
Thank you, everyone.
Thank you. Thank you.
Thank you all. Have a great day.
Thank you.
And thanks to the public.
Thank you.